allow me to introduce our distinguished speaker. All right, we have got the honor of having Dr. Nobuyuki Yotani to share with us today on the topic of advanced care planning in children, right? Yeah. So Dr. Nobuyuki Yotani, he graduated from Osaka City University School of Medicine, and he holds a Ph.D. from the same university. Currently, he's the head of Department of Palliative Medicine at the National Center for Child Health and Development in Tokyo, Japan. He's also the director of the Japanese Society for Palliative Medicine and the chief of the Working Practitioner Group of Pediatric Palliative Care. He's in the development group for the Guideline on Management of Chronic Pain in Children under WHO, World Health Organization, and he's active in research related to pediatric palliative care and advanced care planning. He has got quite a number of distinguished publications related to the topic of advanced care planning. So I'm sure that today we are all very excited to learn from him based on his clinical experience and his research experience in the area related to advanced care planning. So without further ado, I would like to invite Dr. Nobuyuki to start his sharing on the topic. Thank you.
Thank you, Dr. Chai Eng. I'm very happy to have this opportunity. I'd like to thank you to the Dr. Lee Chai Chang and Dr. Chen Chang Po Hen and Dr. Chai Eng. Sorry. And my name is Nobuyuki Yotani. I work as a palliative care specialist at the National Children's Hospital in Japan. Today, I'd like to think about advanced care planning for children with life-limiting conditions together with you. So I will share the slide. This is the last slide. I'd like to proceed using the chat function this time. So first, a little practice. Can you write down your favorite foods from your country in the chat? For me, maybe the sushi is very popular in Japan, yeah? Wow, that means sago, durian, yeah. Let's see, remark. Curry noodles. That's the remark. Sawak kolomi from no sushi. Oh. Okay, like that way you can try to use the chat. Okay. So I will share this right. I will start my lecture. So first of all, I will show the case. Consider this case first. A 4-year-old boy, cardiomyopathy. He has cardiomyopathy after acute myocarditis caused by influenza when he was 1 year old. After that, he was repeatedly hospitalized from heart failure, and his cardiac function slowly decreased despite medication adjustment, ablation, and pacemaker insertion. There was no indication for ventilator assist device due to the renal dysfunction. That means there's no indication for heart transplant. Yeah. He was hospitalized again for heart failure and was treated with several circulatory agonists, but his ejection fraction was less than 20%, and we can get him out of the hospital this time, but we think it will be difficult to save his life the next time. His heart failure. He has heart failure, yeah. So imagine that you are in this situation and you are discussing the future with your child and his family. How do you discuss with him and his family about the future of his life? First is my question. What kind of topics do you discuss with him and his family about the future of his life? Please fill in the chat with your thoughts if you can. And it's okay, you can speak by yourself, okay? How about that?
We have Dr. Eng Su Fang from Malaysia. She has written in the chat his wish and family's wishes.
Mm-hmm.
right? We have Rowena Marie Samaris saying that things that he likes doing.
Mm-hmm.
Dr. Nixon Boon from Malaysia also has written symptoms.
Mm-hmm. That's important.
Hmm.
Wow.
Dr. Lim Zini has written their prognosis, expectations, goals of care.
Yes, yes. Very
Dr.
important.
Dr. Siddharth Sama wishing him speedy recovery. And Mandy Thorpe wishes and hopes what is important to him and his family.
Mm-hmm.
Yep. So Dr. Chong Po Heng also has written what is important to him and his parents right now, his school,
Yeah.
his friends.
Mm.
What is his wish from Dato Zia?
Mm-hmm.
Things may be different in the future from Nora.
Mm-hmm.
Family expectations, child's wishes. Find out what family understands first. There are so many good suggestions coming in through the chat.
Yeah, thank you. Thank you so
Yeah.
much. And the second question, what would you pay attention to when you start the discussion? Please fill in the chat again.
Yeah.
Mm.
We've got parents' expectation, child's
Mm-hmm.
mood,
Mm-hmm.
whether the child is feeling afraid,
Mm-hmm.
his expression, parents' readiness,
Yes, important.
how the family and patient feels physically and psychologically,
Mm-hmm.
his mental condition, the child's
Mm-hmm.
understanding.
Mm-hmm.
Yeah.
Mm-hmm.
His mood and what they want to know.
Mm-hmm.
Acceptance of the disease, age-related language and understanding of the child
Yes.
concerns.
Yes.
Yeah.
Yes.
Okay.
Okay. Thank you for everyone. Yeah. I think all of these things that you have thought about can be called advanced care planning. Advanced care planning is a voluntary process of discussion between an individual and any of their care providers, whatever their roles in the healthcare team. This is the NHS in UK definition of ACP. Yeah? ACP includes the following items: discussing the individual understanding about their illness or prognosis, exploring the option available to them, yeah, and identifying their wishes, preference, priorities, and concerns, and refusing specific treatment if they wish to, and also letting people know their wishes for their future care, yeah. When it comes to end-of-life discussion, DNAR, do not attempt resuscitation, is often mentioned in Japan. What about in your country? Is that the same or not? I think in the hospital world, we often ask, are you asking that family about DNAR? This is often discussed because we want to be prepared for emergency situation. DNAR refers to the following: do not perform cardiopulmonary resuscitation on the patient or a surrogate who is in the patient's best interest. Yeah. A slightly broader concept of DNAR is the concept of advanced directives. This means not only whether CPR should be performed or not, but also the choice of treatment, such as the use of antibiotics or pressure boosting drugs, as well as what to do and what not to do, including living well, should be asked in advance and written down on the paper. Ask the patient about his or her end-of-life intention in advance. Yeah. This will ensure that end-of-life medical care is provided in accordance with the wishes of patient and family. Don't you think so? So there is a large study was conducted in the United States in the 1990s to verify this. Yeah? This is called the support study. I will show the support study slide. Yeah. Subject of this study is included 9,105 hospitalized adult patients with life-threatening illness. After confirming the patient's understanding of their medical condition, skilled nurses listen to the advanced directives and pass the information on to the physician. It was this was done a cluster random trial. That is a study that compared the difference between all patients in one facility receiving the intervention and those in another facility receiving no intervention. It was a big study that the US spent a lot of money and time on, but unfortunately, it concluded that the intervention was not effective. There is no difference in ICU use, medical cost, and patient family satisfaction or pain and other symptoms. Why do you think so? Think that is? We can provide better medical care if we ask people in advance about their end-of-life intentions. So why was it ineffective? Please think about for a while and try to type a chat.
Yeah, feel free to type in your ideas about what is the possible reason for not having the significant difference in all these outcomes. Joanna Tam has written there systemic limitations.
Yeah.
Joanna, would you like to elaborate a little further? What do you mean by systemic limitation?
No, policy limitation.
Policy limitation.
Yeah. Not properly done discussion.
Yeah. That's true.
Yes.
Lack of communication, legislation-related issues, culture in the ICU. Yeah, I think sometimes people tend to be quite worried about letting go sometimes. Yeah. Generalized counseling versus individualized care plan. Yeah.
Family changed their mind. Yeah.
I think it could be related. I mean, based on all the suggestions from our participants, it seems that different places they practice the ACP differently. Perhaps these differences in how they conduct the ACP may actually result in this lack of differences in the outcome.
Okay, I will continue. Yeah.
Yes.
For example, someone close to you is suddenly rushed to the emergency room. For example, it happened to my father. When I rushed to the emergency room and the emergency doctor said to me, Mr. Yotani, your father is a very serious condition. I'd like to think about your father's future treatment. And I found a piece of paper like this in your father's bag, yeah? And show me. The paper contains your father's intention for terminal treatment, yeah? Mr. Yotani, I'd like to proceed with the treatment according to your father's wishes. How about it? How would you respond to that question? Would you say, well, if that's what my fathers want, then please do as he says. No? Actually, I don't think it will work that way. If you know the reason behind it, for example, my father's parents received intensive medical treatment when they passed away, and the experience was so painful for my father, that he didn't want it to happen to him, then you can consider whether the situation is suitable or not. Yeah? But if I don't know the background, it is said that people often choose to use aggressive treatment. The written document alone does not sufficiently reflect the patient's risks. So they assume why it is not effective. So it's important to know the barrier in advance, including their background. That is why the concept of advanced care planning has become popular. Yeah. So advanced care planning is a process that supports adults at any age of or stage of health in understanding and sharing their personal values, life goals, and preference regarding future medical care. The goal of the advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, and preference during serious and chronic illness. So here is an example to help you understand this like a little better. For example, if you go to the curry shop, the owner of the curry shop asks you something like this. What about cumin seed? What about turmerics? What about cayenne pepper? What about coriander? What about cumin powder? What about garam masala? What do you think? Can you tell him that you want more cumin seed or less garam masala? How about it? Even if you are an expert in curry, but you may not be able to do that way. But you can tell them that you don't like spicy curry, but you prefer sweet curry. Maybe you can say it like that. How to convey your intention through spices, yeah? What if we apply this to medicine, yeah? What do you do for heart massage? What about intubation? What about pressure booster? What about blood transfusion? What about antibiotics? What about dialysis? Asking about each medical procedures may be like asking about the spices in curry, yeah? So advanced care planning is very important for to the end of life discussion. But in the pediatric field, there is a number of reports on the difficulty of advanced care planning. The following is a summary of study from UK and US and Japan that I conducted. The following items are answered by physicians as barriers to proceeding with advanced care planning, like lack of training, unrealistic family expectations, physician concern about taking away patients' hope, differences in understanding of prognosis between physician and family or patient. That's a difficult issue that is common in the entire world, but it's a challenge we need to tackle, yeah? The next is who will be target of ACP. It is assumed that all children suffering from life-threatening diseases will be eligible. Patients having a chronic disease, likely to die before reaching adulthood, or may die earlier than patients. They are all the target of ACP in pediatric field. And I don't think this kind of discussion is only for end of life. It is important to share the disease, condition, and values from the beginning of the diseases. First, supporting living with illness. So sharing medical conditions, discussing what is important to them, sharing values, and share the process of the disease getting worse, talk about it over and over, and then think about the end of life together. The surprise questions are a useful way to time end of life discussion. So I will show you. This is a way to ask the child healthcare providers the following questions. Would you be surprised if this patient died within a year? Or if you are not surprised, then you should start palliative care and you should start advanced care planning for the end of life. I think this is a useful way to find the timing of advanced care planning for end of life. Yeah. So now I will show you how to start the conversation. I'd like to share some of my thoughts. That's only my thoughts. Yeah. I think that first thing that is important to is to explore how parents understand their child's medical conditions. I'm involved as a palliative care physician, so I tend to start this way. I think I understand your child's medical condition from the medical records and from the primary doctors. But I would like to ask you directly in your own words how you understand your child's medical condition. So this way, I can check how parents actually understand. There are often more gaps in the details than we think. And one more important thing is to explore readiness. Maybe someone say readiness is important. So like that way, I'm hoping that things will work out too. But if the situation worsens as it did last time, and your child is unable to maintain his current condition, or if the situation did not improve and your child was unable to maintain his current condition, have you ever thought about that? I will ask like this way, yeah. If patient answers that she has thought about it, she has thought about it, ask her specifically about it so that we can explore her values. But if the patient has not thought about it, or if the patient doesn't want to answer, she can say she has not thought about it or cut the conversation off there. I think the method is listening. The method of listening can be useful in this way, yeah. So maybe this from here, the second part, yeah. So if you have some question or some discussion, I will stop the lecture now. Is it okay, Chaitan?
Sure, sure.
Mhm.
I think perhaps that, as mentioned, that really all of us, we have got some minor ways of how ACP is practiced in our respective settings. Would there be any participants in the call who would like to share how is ACP being practiced in your respective settings?
Mhm.
Yeah, maybe we can have somebody to share from different countries, different places. Anybody?
Mhm.
Could I invite maybe like Joanna to share, Joanna Tam, since you mentioned policy limitations, so could you share a little bit about what are the possible policy limitations that are in place in your setting?
Mhm.
So she's put that in Macau, discussion of AD and ACP is not common. Yeah,
Mhm.
yeah. Any particular reason for that?
Mhm.
I think in Malaysia also, because, you know, talking about death or talking about things may not actually go as we hope for in a child, sometimes tends to be a taboo topic as well, which
Yes.
makes it kind of difficult for us, even as healthcare providers, to want to initiate the discussion. Yeah. Yeah, similarly in Hong Kong, AD is not legalized. In Malaysia also, it is also not considered as a legal document, but it is kind of a recommended practice that we actually discuss it, right? Yeah. Refusal of healthcare professionals in accepting there's a limitation of medicine. True. I think that echoes a lot with all of us from different
Yes.
countries. Yeah. So how do we know when is the right time for us to initiate the discussion about an ACP with the parents of a child?
For me?
Maybe Dr. Nobu, you might want to share a bit on that if you're okay with it, or we could.
Yeah. I think that there's no a good time to start the advanced care planning. It's very important to feel the readiness of the patient and family. And so when I say to the patient and family about advanced care planning, so if the patient and the family refuse it, it's better to stop, I think. But sometimes, one time I do so. I feel regret why I do so, but after that, the patient and family talk to me. So I want to talk about it that you asked before. Sometimes the patient will say so. So maybe their readiness is okay. I can try to do it. So it's not it's not good time, but it's better to share. It's better to share the importance of about to talk about the advanced care planning.
Okay. Does anybody else want to talk about it? Saumi said that advanced directive and advanced care plan is not legalized in Sri Lanka and not commonly practiced as well. And Christine said that people tend to think of ACP as talking about confirming the resuscitation status. I think that is a bit of a difference there in terms of, you know, advanced directive and advanced care planning. Maybe anybody else would want to talk about it? Yeah, Nixon has mentioned that it's difficult if we think that the ACP is only end of life planning and resuscitation status, but it's actually more than that, right? We actually want to aim for more than just resuscitation. Yeah, and family influence. Yeah, so good sharing from different settings here. Dr. Nobu, perhaps you want to continue with your case?
Okay, I will continue. But I have to talk about gender. It is not common in Japan about ACP. So and even if the pediatric situation is very difficult in Japan, maybe the same in your country.
Yeah.
I will show the slide next. The following topics are specific to children from beginning of story. So, sorry. So I will show the case. So imagine to discuss the future with a couple whose fetus was diagnosed with trisomy 18. What do you discuss and in what way? What do you discuss and in what way? Please fill in the chat if you thought, if you can. So because as a palliative care physician, I sometimes talk to a pregnant woman who have been diagnosed with serious disease in utero. I have been in many of these situations and would like to share my experience. So,
yeah, I think this is a very interesting case for us to discuss. So we would really be interested to see what others talk about this, because perinatal palliative care itself is also something that is still in infancy stage. I think the only service that I know that actually provides perinatal palliative care right now is with Dr. Lee Chi Chan in Hospital Tunku Aziza in Malaysia at the moment.
Mhm. I think I was a general pediatrician, so I saw the 18 trisomy patient after birth. But as a palliative care physician, I first met the pregnancy. During the pregnancy, it's a very different situation. So,
Yeah. For us as family medicine specialists, because we see the pregnant women providing antenatal care for them during their in the community setting. Okay, so at times when we discover that these things are being diagnosed, but we are not really sure as well what has been diagnosed between the obstetrician and the patient itself. But I think this is also something important for us practicing in family medicine, because we may need to be the one who would actually need to talk out possibilities with the patients as well.
Mhm.
Yeah.
Mhm.
So we've got suggestions there, talking about what is the gestation and whether the country allows therapeutic abortion from Dr. Uzia. Dr. Chong mentioned, what is the one thing that fills your head right now? And Dr. Nixon talking about what are the parents' understanding on trisomy 18.
Yeah, yes, yes.
Hmm.
Okay. Okay, thank you. I was forward, yeah. I think the support in the fetal and neonatal stage is to support becoming a family, I think, yeah. So this is from Dutch group about advanced care planning definition in children. So ACP is a communicative process that enables children and parents to formulate their values, goals, and preference for the future care and treatment, and to discuss these goals and preferences with caregivers and relatives. I think this phrase, to formulate, is important. I think it is important to share the process of forming values over time. So I'd like to consider another case. Yeah, this is actually an intervention from the fetal stages that I experienced. This is a couple whose fetal diagnosis was osteogenesis imperfecta type 2, very severe case. When they first spoke to me, this is what they told me. So they understand that it is a difficult disease, and I make it as painless as possible. And I want to have a family time, and I don't want to be treated aggressively. It was mainly the husband who spoke, the wife, not so much at the time. So the day before the baby was born, when I visited, only mother was in the room. So I discussed with mother. Here's what mother told me at the time. I was frustrated that my husband was having a hard time feeding it. So I have done well so far. Is it bad to not be intubated? What is the happiness of a child who cannot turn over? I want to receive the pain of my child's fracture. She looked straight ahead and told me so. I thought she felt both accomplished and a little confused. Then I was there for the birth of the baby by a C-section. When the mother saw the baby, she looked very complicated. I talked to her after the birth. She said, surprised to be born. The day before the baby was born, I was talking about the funeral with my husband. I'm worried about the future, but I can't think about it. She seemed confusing that the baby she'd been thinking so much about losing was still alive. After admission to NICU, she said to me, I was thinking about my future life on the assumption that this child would die. I have to think about the future. I think I have to think about the new future. One day, but but some but sometime but one day she said, one day when I was going home, I saw this child who wouldn't stop crying, and I felt as if she was asking me to spend more time with her. I felt the budding emotion of motherhood. The baby's condition stabilized after that. One day, however, her condition worsened due to the alveolar hemorrhage. The primary doctor team told the parents that if the baby's condition worsened further, they would have to intubate there, but that would not help. Mother called me and I went to see her. The mother said, I think she's done well enough. It would be too much for her to suffer any longer. I want her to alleviate the pain caused by not intubating her. So I told her I could get the morphine ready. Her parents held the baby in their arms and she was gone. I will show this again to support this budding family form little by little. I think this is very important. And finally, I'd like to think about talking to child himself or herself. This is a result of a survey I did for doctors who treat blood cancers in Japan. The upper green line is a percentage of practice talking with the child himself, and the lower gray line is a percentage of practice talking with the parents. In Japan, ACP practices with adolescents are less likely to talk to the children themselves and more likely talk to the parents. So here is a case I've experienced. 18-year-old boy with cervical sarcoma. So the first time I saw him, he was in the emergency room in pain. His primary doctor asked me about the pain medication, and I advised the doctor about the opioid. So later, after chemotherapy and improvement in his condition, I was talking to him. We were talking about his past. He told me that he had been expelled from high school for violence, like to the friend. But he had gone to a correspondence school after that, yeah. At the time, we talked about his medical condition. He told me that he had heard that this disease was not only limited to the neck, but could also spread to other parts of the body. So I asked him about it. Some people want to hear about metastasis. Some people don't want. Which type are you? And he said, like that way, I want to know about the metastasis, the prognosis, everything. Because I want to know because it's about me. Then he continued his treatment. Once he got better, the disease slowly progressed after there was no cure. And there is no cure, yeah. The tumor in his neck has invaded the cervical spinal cord and he was bedridden. He continued to receive treatment, but his doctor felt that further treatment would be difficult. We talked to his parents and we said that the future treatment would be difficult. He can stay home in his current condition without treatment. The doctor said, I'd like to talk to him about it. But the parents refused to talk about it because they don't want to lose his hope. But at that time, I told the parent what I had said to him. I had talked to him before. After some discussion, we decided to tell him. The primary doctor said to him, it would be difficult to get better your diseases. You can stay at home in your current condition without treatment. You can choose to continue the treatment or go home. I'd love to hear your thoughts. So only silence prevailed in the room. We waited for about 5 minutes, maybe more longer, but there was no answer from him. So we left. Yeah. That night, I wondered if it was good to talk to him about that. But the next day, when I went to his room, he was there as usual. He didn't mention the subject. But after a while, he told me that he wanted to continue chemotherapy until the end, even if it didn't lead to a cure. And he died in the hospital after being treated until the end. Perhaps it would have been difficult to ask him and his intention after he became bedridden. I learned from him how important it is to talk about things in advance. So finally, I'd like to share this photo with you. This is an immunocompromised 4-year-old girl. What I'm doing is talking to her about going to hospice. She has an immunodeficiency as well as progressive lung disease. So her disease has progressed to the point where it's been deemed terminal. So her family wanted her to have a peaceful stay and wanted to transfer her to a hospice. My facility has a specialized hospice for children, and this was the first child. At first, I wondered how well a 4-year-old would understand the option of going to hospice. So the child life specialist helped me to create a storyboard to explain it. And I will try to explain. Can you see the seriousness in her gaze? She listened to me intently and decided on her own to go to the hospice. So I think we medical professionals who treat children need to make an effort to be silent, sincere with children and listen to their wishes. This picture reminds me of that. She toured the hospice on her own and chose to spend her last days in the hospice. She had a wonderful time with her family. She spent 2 weeks there and then she was gone. I learned so much from her. So advanced care planning for children has many difficulties, but I think it is important to involve in each case carefully. So I hope this opportunity will be useful for you. And this is news for you. APHC will be hosted by Japan this year. So we would have link. I'd like to welcome of you all, but unfortunately, it seems that it will be difficult to hold the conference on site, so it will be held online. So abstract submission has been extended until Monday, April 26th. So pediatric sessions are also being prepared. So we will all have a pediatric workshop at pre-conference as last year. So we look forward to seeing you there. Thank you for attention.
Thank you so much, Dr. Nobu. Yeah, we do have some questions in the chat. I think that Janet is asking, what's the age of consent in Japan? I think this is related to the 18-year-old boy that you were talking about.
Yeah, it's a difficult question. Oh, it's no rule in theirs, but sometimes maybe about over 15 age, need a consent. Yeah.
Over 15. So he's actually in, that means that in your case, that child, he was 18. He was already considered capable to make a legal consent in your country.
Yeah, I think so, but actually no. So sometimes 18 years old is a high school student, so maybe family talk to them. It's a kind of different situation. So it depends on the situation. If the family refuse it, sometimes it's difficult.
I see. Yeah. So even though legally they are already able to make that decision, but still in our culture, in Asian culture, family is still a big decision maker no matter what. Yeah.
Yeah, the same, yeah.
Yeah. Then we have got a request from Su Fang. I think she's very interested in how you told the story to the 4-year-old girl about going to the hospice. Could you share with us how did you tell the story about going to the hospice with the girl?
Not difficult, yeah.
Sorry.
No. So she stay only private room in my hospital, but she cannot go out, and she cannot go out of the room. So I will show maybe it's difficult to treat now, and you can stay another room. The room is you can stay with your family, and you can stay with your brothers, sisters, and you can pray there. But the nurse is changing. Another nurse is there, and but you can stay with your mother and father. So I will show the picture of the rooms, and I will show the nurse face of the room. Yeah. And I talk to them. Yeah.
I just wonder as well, because in your setting, you actually have a hospice for children to stay in with their family. Here in Malaysia, we do not actually have that yet. We are hoping to build a children's hospice.
Yes,
That's our dream, but it's not here yet. So I wonder, what do you think about having the child to spend her last days in her home instead of in a hospice?
Sometimes in my country, so home care doctors, there is a lot of home care doctors to cover the, so they can go home. But this situation is difficult to go home because the disease condition is not so good. So the parents worry about to care by themselves. So they stay like a hospital, but not the hospital, and not home. So, but like home. So it's a hospice is a very selective. But in Japan, there is not so much hospice. So it's now developing now. Yeah.
Okay. All right. We have Dr. Zio from Philippines as well. She's asking here, what is the average time that is ample and productive enough to discuss ACP with patients based on your experience?
My experience with the parents, with the
yeah, with parents and and patients, I guess? Does it take a long time, a lot of time?
Yeah, I think that some cases and very early situation, sometimes in early situation, and because of the disease prognosis, so like in pontine glioma, like that way, is a incurable disease. So we talk about advanced care planning earlier, but the like a leukemia, it's sometimes to be cured or not to be cured. So it's difficult to initiate the advanced care planning. So,
Yeah.
but we can explore their values of the of themselves. So I will try to talk about the values of them. Yeah.
Okay. Yeah. And then we've got another question from Joanna Tam. What was the age range of the children in your study, in your research, Dr. Nobu?
Oh, about from 15 to 18. Yeah.
So they are adolescents.
Yes, yes, yes.
Any other people are hoping for a recording? I think, Tanan, we will have a recording, right? It will be in APHN website. And how, if she asks you why you want her to stay at the hospice, how would you answer? That's a question from Maria from Indonesia.
How would I answer?
If she asks why does she have to stay at the hospice?
That's difficult. Well,
Yeah.
why? I cannot decide where she lives, where she stay. So I will just show the information about the hospice and hospital stay, and to explore the values, to what they want to do, and to explore, because before discussing to the patient, I will discuss with mother and father many times. So I explore. I will try to know what they are important to do and what they want to do. So I think that the process is very important.
We've got a question from Mon Chor Von asking if the patient is already at the age of consent, but patient and family have different opinion. Would you consider according to patient's wishes or family's wishes?
Very difficult.
Yes.
But I think I will, if I talk to the patient and their wishes, so I will try to speak with the family about that thing. So like I will show the case. So if I will try to speak with the parents, I will try to speak the patient and what they want to do, what they are important for themselves, and maybe sometimes it's not so separate. We can explore, talk and talk and talk. Sometimes they are not separate the same way. Yeah. So it's very important.
Yeah, it's best to have them in the same room so that we can come to an agreement together, I guess.
Yes.
Yeah. I think here another question about languages, I guess, because like sometimes I guess when you are conveying this questions and discussions in your mother language, maybe it's more comfortable. But here in Malaysia, because we work with many different ethnic groups, so Dr. Nixon here has got a question. He's saying that, you know, some of the questions sounds okay when you ask in English, but when you want to translate into the local languages, it can come out sounding a bit different and can be challenging. Yeah, I think it's true. We do need to explore what are the ways that we can ask these questions about the ACP in our local languages. Perhaps we need to work more in terms of working with psychologists and local linguists about how to ask properly. Yeah. Any other questions? I think, yeah, Dr. Janet is asking, does the family accept well about home death?
Mhm.
Does the family of the child actually accept well about home death? That means that dying outside of the hospital setting, I guess.
Oh,
Because
in Japan, many family.
mm,
Yeah, sometimes yes, but sometimes no, because it's sometimes difficult because they uh, long time they treat in the hospital and then the deep connection with primary doctors, so they don't want to uh, go out to home. They very worry about that things. But
mm,
sometimes I will connect with the home care doctors and share the information in the website and like a Zoom to using Zoom with
mm,
parents and share the information. Sometimes parents, I think it's okay, so I can go home. Sometimes, yeah. Maybe it's very important to share the information to the
yeah.
parents and the local doctors. Yeah.
Yeah, I guess that we do need to support them if we want to allow to make home death actually a reality.
Yeah.
Okay, we do have quite a number of questions in the chat, but I think in the interest of time, I'm afraid I might need to wrap up. I hope you don't mind. But I guess that from today's fruitful discussion and this interesting presentation, there are a few take-home messages from today's session. First thing is that probably we ourselves as healthcare providers, we need to actually overcome the reluctance to discuss an ACP with our parents or patients, yeah, and assessing the family readiness for discussing ACP is also very important because we cannot just push the discussion when they're not ready to discuss, yeah. And the third most important thing that I guess I learned from today's session is that we should actually include the child in the discussion. I guess we are always tend to think that children are not mature enough, but a lot of times they are actually mature enough to understand part of the discussion. And I think this is a very good lesson that we all need to learn from Dr. Nobu, right? That even a 4-year-old child can understand discussions if we bring ourselves down to the level that they can understand. Yeah. Thank you so much for your time, Dr. Nobuyuki. Yeah. So without further ado, all right, because it's already 2 o'clock, all right, can we just give our appreciation to Dr. Nobu?
Thank
We
you
will,
very much.
yeah, thank you so much for your sharing. I think we
Yeah.
learned a lot from it.
No. Thank you.